Good morning and afternoon, everybody, and welcome to the webinar. I'm Max Meijs, and indeed, like Cassie said, in the next 30 minutes, I will take you through the key elements and tools that are typical for the people-centered framework, PCF, as I will use. And then after that, I will turn it back to Kathy, who will then moderate the Q&A. So the title that we choose is Rethinking Our Approach to Analysis, Planning, Implementation and Evaluation of TB Programs. So it's a little bit more than just planning, which we will mostly talk about in this webinar. Good. The objective is that we want to explain to you the people-centered framework for TB planning and programming to interested KNCV staff. So it's an internal webinar. And after the webinar, we hope that you'll be able to describe how PCF can support planning and programming, describe the typical PCF methods and some of them new tools that we are using, make evidence-based choices for optimized TB interventions and programs, and use PCF-based National Strategic Plan for an NSP-based tailored global fund funding request. So the outline covers most of these things that I've just mentioned. We go back to last year in Hyderabad in October 2019, when during the 50th Union Conference, WHO released the PCF user guide, a guide to systematically consolidate evidence along the care continuum, facilitate analysis and discussions for prioritized national policy and strategy formulation. So if we think of national strategic planning, then what you see on this slide is the conventional, let's say, steps that are there in a development process of a national strategic plan. This all according to the current WHO toolkit. So typically countries, NTPs, key stakeholders will need to commit and dedicate relevant human resources, time and funding to this process to ensure a well-informed, efficient and timely process. Requirements and mutual expectations, as well as milestones, will be described and aligned in a roadmap. So that roadmap is indeed your document in how to progress the development for your strategic plan. Normally, the development will take around 6 months from the beginning to the end as being presented here. Two reviews form the foundation of every NSP, an epidemiological review and a program review to assess performance and the results of the current TB program, and the lessons learned and recommendations that need to be considered for the next one. So through a mixture of consultative stakeholders workshops and planning meetings, strategic objectives and key interventions and activities, costs, outcomes and targets will be identified and then included in the new NSP document. After reaching consensus among all stakeholders, the NSP will be endorsed by the senior management of the Ministry of Health. And usually the NSP is then the main reference document for developing funding proposals for donor partners, especially the Global Fund. Now, what happens in the NSP development process using PCF? You see here how this process would look like using the PCF elements. So the 5 highlighted elements that you see here with the red line around it are data consolidation along the care continuum, impact optimization, subnational validation, program optimization, and a tailored NSP-based global fund funding request. The rest of the steps in the development process are, of course, the same, like the consensus, the endorsement, that all will be needed. So why do we think a new approach is needed? Well, there is more data, there's more evidence and knowledge than ever before. Substantial investments in data systems and surveys and new technologies and drugs and tools for screening, diagnosis and treatment have led to the availability of national and subnational data that are comprehensive, current and usable. An unprecedented opportunity to use data on epidemiology, on initial care seeking and health system capacities is now in the hands of many more partners and stakeholders, including local community-based organizations and engaged private service providers to drive programmatic impact towards TB elimination. Now, the vision of the people-centered framework is a future in which evidence is reviewed and analyzed in a patient-centered manner along the care continuum. This will ensure that priority gaps and opportunities are identified so that all people have access to high-quality services for prevention, diagnosis, treatment, and care of TB, including post-treatment follow-up and care. Planning is based on the best available data and prioritized to optimize the impact of interventions and investments. Extraction and review of all relevant data and evidence for use in planning would help countries to identify program priorities and to design effective evidence-based interventions. And then evidence is systematically generated along the care continuum in accordance with program needs and perspectives of patients and communities. So in so doing, countries identify programmatic gaps and generate evidence that will help them to decide how best to allocate resources and to use data to continuously and critically assess their work. Hence, it does not stop with planning and programming. As I said before, data is also used for periodic program monitoring and evaluation. On this slide, you see the partners, because the PCF was jointly developed by the Gates Foundation, by the World Health Organization, the Global Fund, the TB Modeling and Analysis Consortium, TBMAC, Linksbridge, the London School for Hygiene and Tropical Medicine, and Avenir Health, modelers and health economists. And it was refined by KNCV, and this was all done to provide countries with the necessary tools and approaches to optimize their NSPs, as we just explained, in line with the NTB strategy, Sustainable Development Goals, and UNHLM TB country commitments. Technical assistance for the NSP development process will be supported by still the Gates Foundation and the Global Fund, and planned and executed by KNCV as the lead technical partner in close collaboration with WHO, Global Fund TB team, TBMAC, providing quality control on the models, and Linksbridge as backstop for the patient pathway analysis. And I will talk about the patient pathway analysis as one of the tools in a minute. Now, here are the countries where we have used the PCF. WHO first piloted the PCF approach in the 4 countries on the left side. In Kenya, it was used for the full NSP development. In Ghana and Pakistan, it was used for reprogramming, and in the Philippines, it was used for TA planning. On the right side, you see the countries where KNCV, now in the lead, is currently assisting 9 countries in the development of their NSPs. 3 of those, Indonesia, Namibia, and Uganda, have already finalized their NSP, and they have already submitted their Global Fund proposals in March that were countries in window 1. As you may know or not know, but Global Fund has 3 windows for submissions. So these 3 submitted in window 1. This is a busy slide. I'll try to take you through a little bit. So what do we mean by data consolidation along the care continuum? At the top, you see those icons, which are showing the patient pathway from the time that a healthy person, a healthy family, is infected with TB. At first, still the patient is asymptomatic and then developing symptoms before accessing the health system. Then seeking care at a health facility of choice, could be a government or a private service provider, where many will be diagnosed, notified, and successfully treated, but some not. Some may not be diagnosed or not notified. Others may not have started treatment, or have unfavorable treatment outcomes. And lastly, there may be successful treated patients who relapse or who have serious post treatment chronic lung problems. Along each and every step of that care continuum, from left to right, and I've just explained those steps, data can be gathered, documented, reported, and analyzed, building the evidence. And the data that we are looking at specifically here in the PCF on the left corner at the bottom are evidence data, are evidence on epidemiology, evidence on people, and evidence on systems. So again, the same care continuum that you see on the top. What we have done is formulating guiding questions. So the following guiding questions for generating, consolidating, and mapping data along the care continuum are: where and why do patient losses occur in that care continuum in finding and managing people who have developed recurrent TB or post-TB lung problems as the overarching question? Then, what are the best available and latest estimated data and 5-year trends for each of the steps in the care continuum as guiding question for epidemiological data on the burden of TB disease, including its distribution for all different forms of TB? We continue with the question what the differences are and if there are any differences in risk profiles, in patient preferences, and priorities and pathways for any of those steps in the care continuum as a guiding question for people-related data. And those data will be on determinants for TB literacy, for perceptions of patients, expectations, and behavior of people at high risk and developing TB. And lastly, are there any health systems or social protection gaps and access barriers affecting steps in the care continuum as guiding questions for systems-related data that provide insight in the capacities, the performance, the limitations regarding distribution, coverage, and quality of health and social services? So, where do these data come from? Knowing your epidemic includes data from the following data sources. First and above all, surveillance data systems, for example, DHIS2. Of course, also, if a prevalence survey is done in the last 5 to 6 years, prevalence surveys, EPI reviews, furthermore, the global TB reports, annual TB reports, all kinds of surveys, for example, drug resistance surveys, inventory studies, such as mortality studies, and care cascade analysis. Knowing your people includes data from PPAs, the patient pathway analysis, patient cost surveys, very important demographic health surveys, not necessarily specific for TB, but more general health services, relevant national development, health and social protection policies and programs. In here you will find eligibility criteria for social health insurance, for example, and specific studies, for example, adherence and nutrition studies. Then knowing your systems includes data from disease program reviews, service availability and readiness assessments, health expenditure and utilization surveys, national strategies, and global SDG reports. Let's talk more about the patient pathway analysis, one of the tools that provides useful people-centered data for data consolidation. So the methodology was developed by the Gates Foundation and Linksbridge. By examining now the alignment of care seeking with service availability, the PPA may reveal where TB patients experience delay during care seeking, treatment initiation or access inappropriate care during their journey toward cure. Equipped with data from a PPA and from other evidence, TB programs can plan TB prevention and care services in a manner that responds to patient care seeking preferences and accelerates actually the patient pathway to diagnosis, cure, and care. How does that look like? Here you see a visual of the PPA, and I will walk you through now one by one to show you what is all on this visual. So it shows access to TB diagnosis and treatment at patients' initial contact. That is what we have to keep in mind, the initial contact that patients have with the health system. So it doesn't talk about the care continuum part before pre-seeking care. It talks about the middle part of the care continuum. And this is an example for a fictional country. So I hope you won't recognize your own country in it. So let's look first at the rows. So each row represents a sector and a level of the health system. Down there you have a public level 0, which represents lay providers such as community health workers with the now I have to get something out of the way, within the public sector. Public level 1 represents public health centers, clinics, or other primary care centers in the government system. Public level 2 represents public holiday hospitals. Public level 3 represents public referral and tertiary hospitals. And then the same applies for the private sector, where you also have 3 levels, or sometimes only 2 levels. And right on the top, we have even the informal private, which represents providers with no formal training. It could be pharmacies, it could be drug shops, and it could also be traditional healers. Now going to the columns, and we start from left to right. You see in the first column at the left, the total number of health facilities within each of those sectors that we just saw in the rows. Then in the second column, you see initial care seeking, where people initiate care for their illness, specifically at which sector and level of that health system. This column could also be used to represent the point of first contact with the health system. So if you look at the percentages there, then you can see that most of the people initiate initial care seeking is at informal, right at the top, informal private level, and at the public level 1, the clinics and the health centers, and not so much level 2 and level 3. The same thing applies for the private sector. The next column shows the coverage of diagnostic services, the proportion of facilities within a sector and level that have diagnostic technology available. Now, as you can see here, the picture is different. Here you can see that in the public sector, level 2 and 3 have all the necessary diagnostics, and level 1 doesn't have that many of the diagnostics. In the informal sector, usually there are no diagnostics. In the next column, you see a compilation of a multiplication of the 2 columns that we just seen before this. So it shows of all people seeking care for illness, what proportion access a facility that has the diagnostic capacity at their initial point of contact with the health system. And here you can see that it is only 17% in total, mostly the public sector and a little bit the private health sector. Now the same we can say for coverage of treatment services. And there you have the same thing of all people seeking care for illness, what proportion access a facility with treatment capacity at their initial point of contact with the health system. So if you look at this, these are then the observations that we can make looking at this visual. As you can see, most people initiate care in other places, including what we said, the informal, private level 1, public level 1, where coverage actually is low, where there are no diagnostics. So this misalignment that you see here, it leads to low access to services. We mentioned already the 17% in this country would only have access to diagnostics when they initially seek care. And that leads obviously to losses. So let's continue with the next tool that we have developed. These are the data consolidation entry tools, and PPA and the data of PPA are part of all these data consolidation entry tools. The data consolidation entry tool is a new tool. It's developed by us, by KNCV. It is an Excel-based tool and comprises 4 parts. So the first part that you see here has data, only the core epidemiological, patient-centered and systems-related data. It's the country profile. So this is what we will make for each and every country. Most of these data is available in the WHO Global TB database or other accessible databases, and can therefore be pre-populated. So only a simple review is then needed by the country. The second, third, and fourth part include core data on people not accessing the health system, people presenting at public or private health facilities but not diagnosed or notified, and people notified not treated successfully. So you recognize here again the care continuum. For more detail, for example, when there is a big gap in the care cascade, supplemental data on in-between cascade steps are needed and can be added, or first have to be generated and later added if those data are not available. For example, the drop between individuals screened positive for TB and patient diagnosed can be too big. Then what you can do is look at the proportion that provided the sample and the proportion that was tested with expert. That can shed more light on the reason for the overall big gap. Countries can update and review data anytime in this data consolidation entry tool. So here you see how data are entered, how they look like, how the entry forms look like after semi-automated entry of data. An automated basic data visualization on the right can be used and copied into PowerPoints, for example, or in reports. This is another example of a data entry tool with the automated visualization. And again, another example of the data entry tool with automated visualization. So what we have also developed is the PCF Dashboard, which is an automated data visualization tool and can be used by the country themselves. Again, you recognize the TB care continuum, and you recognize the epidemiological data, people-centered data, and system-related data. And you see all the icons there. So this is a screenshot of that PCF dashboard. Now, what happens if you would navigate over those cells that you can see for all these data and steps in the care continuum? When you navigate over a cell, immediately the data will pop up, as you can see here. And navigating to another cell, data will pop up, as you can see here. If you don't have data, but if there's any information that you would like to share, you can add this also into the data entry tool, and that information, for example, data are currently being gathered or being analyzed, that will also pop up. Let's continue to the next element of the PCF, impact optimization. So the conceptual framework that you see there, again in a different way now for the care continuum, using this TB data and evidence in planning for intervention optimization, centers on a methodology of reviewing the evidence on reasons why people don't make it to the health systems, or why they are not diagnosed or notified when presenting, or why people are not notified but not started on treatment or not treated successfully. Now, the following methods are applied to answer some key questions. First of all, problem prioritization, which with which are the biggest problems as key question. Then, root cause analysis, with what contributes to the identified problems as key question, followed by intervention identification, with what are priority solutions as key question, and lastly, intervention optimization, with what is the expected impact of these solutions as a key question. Now, impact and feasibility are plotted in a quadrant to identify the high impact and also feasible interventions. And also at this time, I have to take you back, and also this is the time where decisions should be made on potential collaboration. So who is responsible for that intervention? Who needs to be involved? And who is implementing? Let's go to the next element of the PCF. So we are closing gaps. We are closing the gaps along the care continuum. And we are optimizing our interventions using the PCF. But this PCF element was prominently piloted in Ghana and in Pakistan, subnational validation. Of course, we all know that subnational areas are heterogeneous, and therefore subnational responses should be different and tailored to address TB in local contexts. If we have reached this far in the TB planning process, after the intervention optimization and subnational validation steps, followed by costing of the interventions, another innovative approach is the use of mathematical modeling, more precisely for TB, TIME, which stands for TB-HIV impact modeling and estimates. So the tool supports the situational analysis of the current burden, such as notifications, incidence, prevalence, and mortality, and consequences of inaction. Now, an NSP that is informed by modeling is more rational and can inform decisions for prioritization in funding requests through intervention modeling, comparing and projecting the budget to best impact of different interventions. A word of caution though, TIME is a decision support tool, not a decision-making tool. We have seen that PCF generates and utilizes local evidence in a participatory manner and applies tried and tested targeted impact and economic modeling to help stakeholders to select an optimized set of proven people-centered interventions and targets in terms of both future health and economic outcomes, based on their available and projected resources. So at this stage, a country may want to consider several resource scenarios. For example, existing funding levels, increased funding, or an aspirational fully financed budget. Shown in the onion is the example of Kenya. Under each scenario, the package of high-impact interventions that most effectively and efficiently addresses priority problems and root causes will need to be determined and was determined in Kenya. So the budget with existing funding levels can be used by Kenya for immediate action, while the other budget tiers can be used as the basis for future funding requests. Now in Kenya, for example, they used with 25% more funding, they will achieve, and you see that in the right, they will achieve actually 16% more decrease in TB mortality and 10% more decline in TB incidence. And with a fully funded NSP, the results will further improve towards achieving the NTB strategy, the SDG and UNHLM targets. PCF-based NSPs will enable countries to negotiate harmonized and optimized engagement and resource allocations from domestic and external stakeholders alike. Confirmed by the Global Fund in December 2019, selected countries with costed people-centered evidence-driven NSPs may qualify for a simplified, fast-tracked Global Fund funding request stream. And the funding request will be tailored to the NSP. How that looks like is shown in the next slide, which is the last slide of this webinar. So what you can see here is that you simply have to tick all the items that are mentioned that are required by the Global Fund, and then just fill the page or the pages